Now, what I like to do is briefly, I'll move us through. Today's talk is Anyone Care About Clinical Outcomes, and we're going to talk about simplifying diabetes management. And we did our witty title, Anyone Care. So Tina, I'll introduce Tina next, and we'll do our conflicts of interest. So Tina, why don't you just say who you are?
Hi, good afternoon. My name is Tina Koronik. I'm a family physician and the director of PEER, which is an evidence-based medicine group looking to empower primary care through evidence. And I'm an associate professor in the Department of Family Medicine at the University of Alberta.
Great. And so I'll just do our conflicts of interest, then I'll do some housekeeping pieces. So our conflicts for Tina and I are very, very similar. We've both received speakers honorarium and travel payments from a bunch of sources, mostly chapters of colleges of family physicians of Canada, some various hospitals and hospital districts, and university CPD departments. But we haven't received funding from industry for any of that. And just to remind you that includes some honorarium and expenses for travel. We've received funding for clinical trials and some of our other work through research grants. And so the Canadian Institutes of Health Research, PRIUS grants, all sorts of others. I myself am employed by the College of Family Physicians of Canada, and Tina is employed by the University of Alberta. So that kind of wraps it up. We haven't taken funding from profit-based companies or industry. Now, just a reminder for those of you watching on YouTube, and I think that's all of you because there's no other way to watch this now, but it is important to realize that we appreciate your comments and feedback as we go and questions. So if you have questions, please enter them into the chat function. If you can't see the chat function, you'll have to log in through either Google or YouTube account. And if you can't see it, then you might be in full screen mode. The questions will be addressed towards the end of today's webinar. Also, you'll note that as we go by, there'll be people dropping things in the chat window about how to claim credits. So if you'd like to claim a credit for today's webinar, you simply click on that and follow it through. Remember, it has to be done associated with the live event. So please save that link or click on it towards the end of the webinar so that you can get those credits. Okay, that is all of the housekeeping stuff, and we are going to jump now to the presentation itself. And Tina, I think this is where you take over. I'm going to go grab coffee. I'll be back in about an hour.
Great, thank you, Mike. Yeah, leave me in charge of making sense of diabetes. It's just a simple task that we can easily cover in 40 minutes. So we'll start with a summary, an editorial we found about a year ago in the Journal Watch, which was entitled Sulfonylureas for Patients with Type 2 Diabetes, Still an Option. And this editorial was written in response to some research that had come out that showed that the prescribing for sulfonylureas had sort of begun to decline. And so the author recognizes, he says, yes, sure, certainly in the past we have seen some evidence suggesting that these are associated with cardiovascular harm. But he said, hey, there's a new trial out that compares them to DPP-4s and shows no real difference in harm compared to them, and they're really cheap, and hey, they lower sugar. So really, he was saying, you know what, they're cheap, but they probably don't worsen cardiovascular disease, so you should consider prescribing them. And some of us might look at this and think, this is bordering on insane. What are we trying to do with regards to diabetes management, and what are we supposed to be focusing on? So sometimes we focus on surrogate markers in place of potentially other things. And so there's some great stories about historically about how we've done that. And we tell ourselves why we're treating something. So one story is looking at patients who've had a heart attack. So after you've had a heart attack, the timing of your heart suddenly gets thrown off, and all of a sudden you're having these irregular beats. And so that was noted to be somewhat common in people following a heart attack. And so when you had these irregular beats, that often ended you in the grave. So they found this correlation. And so what the obvious conclusion would be, well, we've got to get rid of those abnormal beats. So if we can get rid of those beats, we can stop that outcome. So we found a medicine, an antiarrhythmic medicine, a couple of them, econide and flecainide, that would stop those beats. And actually, when they randomized patients, they wanted to find people where these were cutting beats at least 80%, on average about 85% of the abnormal beats were being cut out. So this seemed like, genius, brilliant. We're going to stop those beats. We're going to be saving lives. And so this was used, and ultimately they ran a randomized controlled trial. This is a true story of a real trial where they actually had trouble recruiting patients because some people felt it was unethical to not give patients this medication. And after 10 months, what we found is those who had received placebo, about 3% of them had died. And those who had received treatment, about 8% of them had died. And this was what it really was, is we were harming patients. So we killed 1 out of every 21 people coming to the CCU for our help with the best intentions, and a really, really great story. And so a great editorial on this says, this really challenges our conventional wisdom because we believed that this was going to work. And it turns out it didn't.
That was a real turning point in evidence-based medicine, where they kind of said, wow, our belief in a surrogate marker, our belief in a physiologic story might have led us down the wrong path. And you would think with that turning point back in the late 80s, early 90s, that we wouldn't fall into these same traps, but we do all the time. And we're just going to give you 2 stories because we want to kind of lay the groundwork for what other stories are being told in reference to diabetes and have you kind of reflect on that. So when we heard about oxidative stress, we heard about things like free radicals, and we really do market disease. Don't forget that, because it's important to remember that things like hypertension are called the silent killer, and osteoporosis is called the silent thief, and MIs are called heart attacks for a reason. So oxidative stress, we use words like free radicals and fancy words like lycopenes and stuff. And then we show pictures like this that give the impression that we really, really understand what's working at the cellular level. And so much so that we can even talk about the antioxidants function at the individual organelle level. And that leads us to believe that with that amount of knowledge, we must be safe in assuming that all we need to do is give more vitamin A and E to prevent oxidative stress. So we just give the antioxidants and everybody is happy. But unfortunately, people went ahead and did research. And I say unfortunately with tongue in cheek, because really we needed a lot of research before, as physicians, we were willing to accept that this was a false theory. It took 300,000 people to be studied before we could go, maybe that physiologic mechanism isn't what we thought it was. Because what the research found is we were killing 1 in every 200 patients over 3.5 years. And if you were like me back when this was popular, you were sending patients, or you were doing it yourself sometimes, and putting patients on A and E vitamins at high doses to prevent oxidative stress, particularly for those at risk for cardiovascular disease. What's interesting about this one that's a little different than Tina's story is that this now, because it went into the public, just like we have with cholesterol and sugars and everything else, once it's in the public, it really has a life of its own. And you can no longer slay that theory with really good research, because there's still tons of talk about antioxidant nutraceuticals and all sorts of things. So these things, once they're established, they're very hard to erase. And Tina and I are working on a presentation now that talks more about our thinking around once something gets embedded in our mind, how hard it is to erase that or move us into a new understanding. So that's our 2 kind of examples, but let's talk about how that relates to diabetes.
Right. So when a patient comes in and presents before you, what are those patients worrying about? How many times do you have a patient who's come in and said, I'm really worried about my microalbuminuria? Now that one is a bit ridiculous, but probably just because that hasn't hit the media. But we certainly do have patients who come in and say they're worried about their cholesterol. In fact, just the other day, I had someone come in who was very anxious about potential cardiovascular events because they'd been told their lipids were a bit high. Their overall risk was less than 3%, but they have been taught that cholesterol is dangerous. Some may be worried about sugars or A1Cs, but again, we've taught them to fear these largely, and would largely say that these are surrogate markers in and of themselves. Patients won't notice them. And so we really have to take a step back and start distinguishing between these things. So what we can measure, because we love to measure things, and we can measure it and we can improve it, and then it looks like we're doing something, versus what matters to patients. And sometimes that's harder to measure, but we have to have that understanding. So what are the things we can measure in medicine? Well, we can measure sugars and protein in your urine and your blood pressure and monofilament tests. But what matters to patients ultimately is survival, quality of life, heart disease, stroke, pain, sensation, vision, avoiding those outcomes that are going to affect their quality of life. And so as clinicians, it's really on our part to keep that in mind.
And so in a way, I always liken it back to this sign, and some of you who've seen me present before have seen me present this sign, and I love it. It says, "Caution, this sign has sharp edges, don't touch the edges of the sign." And in fine print, it says, "The bridge is out ahead." So we talk all the time about sugars and that kind of thing, but what we're really talking about, what we're really concerned about, are the things that really matter, like heart attacks, strokes, death, that kind of thing. And so what we're going to do is spend a little bit of time talking about how common are those things? When are they going to occur? Who gets them? That kind of thing. And so that way we won't be missing what really matters. Because there are the things that matter, the things that Tina's gone over, and the things that you can control that you should focus on. Okay, so what are the bad things that happen? Well, we can imagine what the worst things that happen might be. So there's two real things in my mind. There's the worst thing that can happen. You could debate, maybe it's a terrible reduction in quality of life. But if it's not that, it would certainly be death. And some would argue that's the worst outcome. So because death is it's crystal clear, and we know it's something that we can't argue whether it happened. Believe it or not, you can argue whether an MI happened for some patients, but you can't argue about death. So looking at death as the final outcome, let's look at 75-year-old patients. On the average, 40% are men. What happens to them over 5 years? And we'll type patients who don't have diabetes, those who have it for less than 10 years, and those who have it for greater than 10 years. So the number without diabetes, 10 out of 100 will die in the next 5 years. In patients with diabetes but less than 10 years, 14 of those will die. And for those that have had diabetes for greater than 10 years, you can see that 22% will die in that case. So what's important to also note here is, what are they dying from? So as diabetes progresses, more and more patients die as a proportion from cardiovascular disease. And so that's important for us to also recognize.
Okay, so what other bad things happen to patients? So one of the things that you frequently hear is that diabetes is a leading cause of renal disease and dialysis requirements. So there's been some really interesting evidence following patients who have diabetes throughout over a period of time, and looking at what do they develop. So one of these studies followed about 1,000 people with diabetes for 10 years. And when these people were admitted or first started to be followed, about 50% of them already had micro or macroalbuminuria. So they had already shown some initial signs of renal disease. So this was really fascinating. When I first saw some of this data, I was really surprised, because I had always thought, that was just a major outcome of diabetics. So at 7 years, how many patients would need dialysis and how many would die? And just think in your mind, how many do you think, starting with 50% of them already having micro or macroalbuminuria, how many would progress to sort of end-stage renal failure requiring dialysis? And the answer may shock you, it's 7. So that's a very significant outcome, and that significantly impacts the patients who are requiring dialysis. But the numbers are much smaller than I would have expected. Now, what about overall death and cardiovascular disease? So if you look, about 35% of those patients at the end of this time will have passed away. Of those who passed away, half of them passed away from cardiovascular related death. So when you look at the two and we think about what are we really trying to prevent in our patients with diabetes, one of the big things that we should remember is that cardiovascular disease is one of the biggest causes of death in this group of patients. And while the other outcomes are also important, if we're setting our sights on what's the biggest killer, it's definitely cardiovascular disease. But there's lots of other things that happen in diabetics and lots of data that's looked at this. So if you look at patients who were enrolled in the UK-PDS, so the UK-PDS study is a bit older, tended to enroll patients who were younger and earlier on in their diabetic journey. So if you follow them for about 10 years, about 18% will die, 14% will have had a heart attack, 5% will have had a stroke, and about 0.6% will have gone on to renal failure. If you look at other trials, say Advance, where they had patients who were a bit older, who'd had diabetes for a longer period of time, their risks of these outcomes are a bit higher. So of course that makes sense. It depends on your baseline risk, but at 10 years, about 20% of them had passed away. 6.5% had had a MI, about 9% had had a stroke, and renal failure was about similar. The other question that comes up is around amputation. So if you look at trials that have reported on amputation outcomes, again, it depends on the baseline risk of the patients involved. So sometimes there's all these little details that need to be sorted out, but patients who are at higher risk when enrolled down the road, about 12% could have experienced an amputation at 10 years. But even then, remember that cardiovascular disease is significantly more common, about 4 times higher in those groups as well.
Now, some of the other things that can happen are things like vision loss and loss of sensation. We put those as outcomes that matter. So let's just look at how often they occur. So 3-line vision loss on a Snellen chart occurs in about 20% of patients. And if you do aggressive management over about 5 to 10 years, you can see about a 1.5% reduction in that. In loss of light touch, you go from about a 14% risk over 10 years down to about a 12% risk, reducing it by about 2%. So that's just some examples of your baseline risk of these events.
Okay, so what are the outcomes that we can influence? And when we look at the outcomes that we've just kind of summarized, so there's macrovascular complications, heart disease and stroke, and then the microvascular, including vision, sensory outcomes, renal disease. So can we influence them? Yes, we likely can. And we're going to run through some of the evidence around all of that, but it likely requires a comprehensive approach. It's not just one single target that we're trying to reach. We also have to consider quality of life, because as Mike mentioned way back, what is the worst outcome, a terrible quality of life or death? Some people would even argue that. So that needs to be considered in management. And that's what we're going to talk about now.
Perfect. And so we'll talk a little bit about aggressive management, but only very briefly, just to remind you that some studies found an improvement. This was with metformin in the UK-PDS study, and this study found it got worse with aggressive management. That was a cohort in older patients. But just a reminder that it's not entirely clear that aggressive management is great. This is a mortality curve related to A1c levels, and you can see the lowest mortality occurred kind of around a 7.5 to an 8 A1c. This was in patients on insulin. This is looking at patients with long-term care who are getting assistance in the home and their risk of ending up in long-term care. And you can see that the risk of going into long-term care actually was higher. This is not a clinical trial. This is an observational study. So just remember that it comes with more biases and confounders, but it looks like lower A1Cs are worse in this frail subgroup. And there's more research coming out about this. We don't need to spend a ton of time on it. It shows pretty much the same thing, that the ideal is often around a 7.5% for mortality and things like that. And there's no real change over time. We're seeing this consistently in the observational data, and the RCTs don't show that aggressive management results in much, except some reduction in tiny reductions in microvascular. I indicated to 1.5 to 2% over 10 years.
Yeah, I think those mortality curves are just fascinating. It's especially from the era where I graduated. I always thought lower was better, and so to finally put that into perspective, it's like I think we have other talks where we look at mortality curves, looking at blood pressure or salt or whatever. Lower of many of these things results in harm. The other thing that comes with aggressive A1c management is that sort of aggressive diabetes care requiring frequent blood sugar testing, requiring all the dietary changes, requiring all the interventions associated with that. And so this was an interesting study that was published a number of years ago, looking at quality of life. And what they did is they just took patients in the community and surveyed them who had diabetes, and asked them, how does this sort of aggressive sugar management affect your quality of life? And quality of life, for those of you who don't recall, one is nearly perfect, and 0 is pretty terrible. Quality of life that we see sort of associated with something like a mild stroke or angina is, about 0.7, 0.64. So these are all potential outcomes of diabetes. But when you ask patients, what is the effect on quality of life with comprehensive diabetic care, it's actually pretty similar. So it's similar to having a stroke, essentially. So that requirement, all of a sudden a patient comes in, you have diabetes, and now we have all of these things that you have to do, can significantly impact their quality of life. Now, there is another study that was published in 2011 that said, it wasn't quite so bad. However, what I think is interesting about that study from Accord in 2011 is they surveyed people who had willingly entered a randomized controlled trial on aggressive diabetes management, and they had excluded patients who weren't interested in checking their sugars or being involved in this type of aggressive management. So they've selected a different population who were all basically told, we're hoping to improve your outcomes with this aggressive management. So I would say the first one is more representative of our general population of patients. Just being aware that a lot of the things we're doing are potentially impacting their quality of life.
Now, I remember those, Tina, those first visits back in 1999, 2000, when I would tell patients they were diabetic, and we would just go over the barrage of medicines we wanted to start them on, the long list of things like you have to monitor your sugars now, you have to change your diet, you have to, like, all of these things, and we overwhelmed them. And it doesn't surprise me that the quality of life was lower at that time too. So now we've told you some things that can seem discouraging. This is my cat, by the way. This is how he sleeps.
Great picture.
But I've talked to him about considering fluoxetine, but he's not ready yet for the change. So anyhow, so how do we manage diabetes? So this is from the Steno trial, and this is to kind of, if you're feeling like my cat Soul, you'll know that this might help you along. So this Steno trial, what they did is they took patients with long-term diabetes, and they also had microalbuminuria. So these are the patients who are highest risk. And they aggressively managed them for 7 years, and then they added 6 more years on. And they started with 160 patients only. So that's pretty impressive low numbers. So they really did expect something to happen, and it did. And these included, like when we say aggressive, they got them to exercise more. They did all sorts of things like contacting them at home, following them up at home. They did things for sugars. They did things for blood pressure. They did things for lipids, which was almost entirely statins, for example. And they just really did a lot for these patients, but it was comprehensive. Now, interestingly, they also set targets. And at the end, only 1 patient out of 80 actually attained all targets. So that's just a reminder for us that it's not about attaining targets. It's about being on the right therapies, okay? And so most of these patients were on ACE inhibitors, they were on statins, they were on metformin, and they were exercising and all of that stuff more. But you can see 20% absolute reduction in mortality. These guys, because they were at high risk for renal disease, they had a much higher chance of progression, so 10 times higher than the one that Tina pointed out to you. But still, this reduced it with a number needed to treat of 16. There's only been 2 trials that I'm aware of that actually reduced the risk of dialysis in diabetic patients, and this was one of them. So very, Very impressive stuff. And you can see the total number of cardiovascular events, because these high-risk people was almost 3.5 to 2. So really very impressive. They tried to do it with new diabetics, and people say, oh, that failed, so it doesn't work in new diabetics. But that's actually a misinterpretation of the study. Because the standard of care now has become for many patients to get statins, metformin, ACE inhibitors, etc., as their disease progressed. When you compared the groups, they would often only have a few percent difference. So the intense intervention group, 80% of them were on statins versus 72% were on statins in the placebo group, that kind of thing. So there wasn't enough separation to really see a difference here. So I don't think we can dismiss from this trial result that it doesn't work. I think Steno was early enough that we weren't regularly thinking of these interventions. So that leads us to here, and that's our lifestyle. We're not going to be quite like Homer and smoke butter, but what can we do in our lifestyle interventions that will help us?
Love that.
The adjunct therapies. I know it probably took me 2 weeks to get that to work, Tina. So Tina, talk about lifestyle, because that is such a key element of this.
Yeah, so there's some really neat studies looking at lifestyle interventions in diabetics. This was a small RCT, just under 100 Danish patients who'd had diabetes for about 5 years, average age 55, about half of them were male. And they were enrolled in this sort of intensive lifestyle intervention. And the intensive lifestyle intervention, reading it made me feel guilty, like I should go for a run. But they 5 to 6 days a week, they had some type of aerobic exercise that was up to an hour of length. They included resistance training a few days of those weeks, and they had a lot of support. A lot of these were originally led by exercise specialists. And what they found and what they did, it's an interesting trial. So they were looking to see if you could get off some of your diabetic meds. And so as your sugars went down, they would take you off a medication. And then your sugars would go up a bit. But what they found is at the end of a year, there was a huge difference in patients who were able to get off some of their diabetic medication. So about 74% in the intervention group versus 23% in the sort of regular treatment group. So number needed to treat of 3, which is pretty good. They also looked at weight loss. So surprise, surprise. How many patients achieved about a 10% weight reduction, about 30% compared to 3% with a number needed to treat of 4. So what were the harms of this trial? Well, mild hypoglycemia, and actually just to point out, severe hypoglycemia did not differ between them. And mild was defined as like you told the nurse you were hungry, or a little bit dizzy. And then a little bit of MSK injury, but again, those were like mild MSK pains. They recorded basically anything. So the bottom line is, if you can, and this is the piece that's sometimes trickier, is getting your patients to participate in that. But if they do, it works. And over 50% versus 15 can actually stop medications plus experience weight loss. And so again, what patients can do for themselves is so much more than what we can do for them. But there was a slightly higher risk of MSK injuries that just needs to be considered, because you don't want that and then no exercise at all after that.
But this is not the only study. That what I'm amazed at is there's 2 studies that have now shown this kind of thing.
Yeah, absolutely. So this is another nice primary care study, 300 patients who had had diabetes for 6 years or less. They weren't on insulin, and the average A1c was about 7.6. And so these patients were randomized to a pretty restricted diet, so about 840 kilocalories per day for 3 months, and then a slow reintroduction of some foods. So the goal with this was really to get patients to lose at least 15 kilos. And what they found again in this particular trial is that significantly more patients were able to lose that. So about 24% of the patients enrolled were able to lose that 15 kilos with the number needs to treat of 5. And from that, remission of diabetes, meaning their A1c went down, and they weren't on medications was 46% compared to 4% with the number needed to treat of 3. And if you were in the group where you lost 15 kilos or more, 86% of them went into remission. And I think Mike and I were chatting about this briefly, or so is it like a cure or is it remission? Maybe it's a bit of semantics, but either way, they weren't, their sugars were fine and they weren't being treated for diabetes anymore. In addition, quality of life was better for these patients, which is, again, another really important outcome. It's not like we made them feel worse, but their diabetes went away. They actually ended up feeling better. So surprise, weight loss can resolve diabetes. And again, really being able to say that with confidence to our patients, like there are absolutely trials that absolutely show if you can lose weight, we can get these numbers back to normal. And similarly with exercise.
Exactly. I was just going to say with exercise. And this one, they use this counterweight plus, but this is kind of, to me, like the study of reducing bladder infections in women with recurrent bladder infections that they used. I don't even need to use the brand name of that water, but I think any water probably works. And I think any calorie restriction that's a starvation diet, which this was, works. So I don't buy the marketing here at all. I think that it's, I think any calorie restrictions can work, but it has been mentioned that this is why. I don't think so, but anyhow, so what if patients can help themselves? So Steno went over the way to really stop diabetes, but what about some of the other things? So can't someone else just do it? And there are 3 areas that we need to kind of focus on in addition to just straight weight loss and activity. In addition to what Tina said specifically, to lose, to put diabetes in remission. And those 3 things, they haven't been studied for hard outcomes for the most part for diabetic patients, but we're going to talk about the studies that have shown they are beneficial, and I think we can extrapolate a lot of that to our diabetic patients. The first one is a smoking cessation study. This is immediately after MI, and they randomized them to aggressive push to stop smoking versus not. 90% of patients after their MI said, I'm going to stop smoking, and only 11% had stopped by the end. Of those who were in the aggressive arm, it was over 30%, and many of them had reduced. But the number needed to treat to prevent death in 2 years was 11. So that's a 9% absolute reduction in death, which is huge in 2 years. Absolutely huge. Bigger than all of our post-MI medicines together, I think. So that is so important and so powerful. Activity. This was a study that randomized patients with stable angina to either a stationary bike or angioplasty. And the stationary bike was for all cardiovascular endpoints like repeat angioplasty, MIs, all sorts of things. But the absolute difference was 18%. It was 30% in one group versus 12 in another. And the 12 group, the low group, was the bike. Bike was actually better than angioplasty. This was a study of the Mediterranean diet in people post-MI, and you can see the number needed to treat there is dynamite. If you haven't had an MI, the number needed to treat goes up to 70. But still, again, the Mediterranean diet consistently shown. So these are things that we need to push for our patients who can't make that big step to lose enough weight and to exercise enough to actually put diabetes in remission.
Right. So we've talked a lot about lifestyle things that patients can do for themselves, but I guess it's time for us to talk a little bit about pharmaceuticals and medications that potentially could assist with this. So what about statins? I mean, statins are kind of a nice one. There's lots and lots of research on this. Most of this systematic review of 18 randomized controlled trials, almost 60,000 patients, was looking at primary prevention with statin use. And what they found is that cardiovascular disease was significantly reduced. So about a 25% reduction, which is similar to what Mike was talking about with the Mediterranean diet. So 9% versus 12%, number needed to treat of 35. So mortality benefits with statin is also there with the number needed to treat of 132. And lots of other studies find similar. There's certainly studies that look at patients with diabetes and statin outcomes. And again, report similar benefits. So the bottom line is that they do reduce cardiovascular disease by about 25-30%, and slightly reduce mortality over around 4 years. So certainly something to consider in our diabetic patients.
ASA is a little different. So the results at best are inconsistent and overall suggest that we don't need to give ASA anymore. That was certainly part of the original 4 drugs back in 2000 that I would prescribe, but now I don't jump to ASA at all. You can see there's a lot of studies that have been done on this. The only one that found a benefit went 7.5 years and enrolled 15,000 patients. The reduction in cardiovascular events was 1%, but the bleed risk went up 1%. So to take a medicine for 7.5 years straight for an exact balance of harms and benefits doesn't seem logical for most. So that one's kind of off the table. Hypertension, though, is a whole different matter, and this is something that I do want to stress. And when I would have residents go in and see patients with diabetes, they would come back and tell me about the patient's A1c and other things, and I would always ask, the most important thing you can tell me is what their blood pressure is. And why is that? Well, it turns out that nothing beats blood pressure. If you look at BP, the relative reduction related to cardiovascular disease from blood pressure management is 50%. This is not the patient. I'm not talking about the patient who has a BP of 142. I'm talking, these patients are 160, 180s, those kind of things. And when they aggressively went after their blood pressure to get it down around 140, there was a good reduction in cardiovascular events. You can see a 50% reduction. So lipids come the next closest, in 25, maybe in high dose up to 30, 35. Sugars, 15% for some. We'll show you which ones can actually do that. In ASA, probably nothing. So when you're talking about diabetic patients and preventing things that matter, other than the lifestyle stuff that they do for themselves, like stopping smoking, the interventions that we do as clinicians, it's blood pressure, blood pressure, blood pressure, and then lipids, then sugars, then blood pressure, and it's just, we do have to remember how important blood pressure is. But moving on to glucose drugs, we're in a war here. It's a bit of a challenge because, and I used to think these pictures that I ended up getting are fake, but they're probably not. My daughter at her school was collecting pop can tabs to prevent diabetes. Like, you can't make that up. I can't make that up. I just kept saying to her, really? Was that at your school? Anyway, she's out now at university. Hopefully that's not happening there. But anyway, you can see there's a battle here about how we approach diabetes. We're going to start with the drugs that maybe don't have great outcomes. Tina?
Yeah, for sure. One other thing, when we started talking on this a while ago, one of the things that really shocked me was how originally drugs for diabetes were approved. And they were approved based on evidence of glucose lowering. They were not required to show any other patient-oriented outcomes. So a lot of these drugs, especially some of the older ones here, were approved based on the evidence around their ability to lower glucose. So all of these, acarbose, DPP4s, insulin, the TZDs and sulfonylureas, lower sugars. But none of these have evidence from randomized controlled trials that report on patient-oriented outcomes. So they have no evidence. So acarbose and DPP4, for instance, no cardiovascular benefits, no evidence of consistent microvascular disease. And I'll just put in a plug. I think, Mike, you did a tool for practice on DPP4s, which was one of my favorites, entitled, hundreds of studies and still no evidence on cardiovascular outcomes. TZDs, you'll likely be familiar with those, like rosiglitazone, which actually increase things like congestive heart failure, fracture, and the pioglitazone has some evidence around increased risk of bladder cancer, but at lower sugars. Sulfonylureas are really interesting, no evidence of cardiovascular benefits. There's an old RCT that showed a significant increase in cardiovascular disease mortality with their use. That was a second generation, I believe, but there's also increasing observational evidence suggesting they may be associated with increased harms, maybe some weak evidence around the improvement in retinopathy for those.
Yeah, and that's from one RCT, and then subsequent meta-analysis suggests that's not even true, which is disappointing.
Yeah, absolutely. Yeah, absolutely. And then insulin. We use insulin a lot, but there's the evidence around cardiovascular benefits isn't really there. And again, weak evidence on microvascular benefits like retinopathy. And I will just say it's shocking and somewhat disappointing in a disease that we've had for so long we still have so many medications that don't have evidence of benefit in patient-oriented outcomes.
Mm-hmm.
All right, and then here's the other piece that we don't always learn about in medical school, but I think is really important, especially depending on your population, and is the cost associated with these drugs. So we're giving patients drugs like DPP-4s that are $300 every 3 months, and so depending on coverage, even if you have coverage, somebody's paying that somewhere. So there's a lot of money being transferred for drugs that may not improve, that don't have evidence of hard outcome benefit. So sulfonylureas, so just to circle back to the first editorial we showed you around the sulfonylureas are still an option. Even within Canada, if you look at previous guidelines would recommend sulfonylureas as a second-line agent. And the rationale for that was they're cheap and they lower glucose. So that's why we've had them kind of, I was always taught that was the number 2 agent for sure. And of course they're certainly very inexpensive, which is great. But are we helping our patients with them?
And that leads us to the drugs that work. And interesting, this is a shorter list. So the first three that the three that you're probably aware of now is metformin, SGLT2s, and GLP-1s. If you look at metformin, the data is not 100% clear, but if you use the UKPDS, which is the most idealized data, it looks like a cardiovascular risk reduction of around 35% and a death reduction of around 35%. Other studies aren't consistently showing that. Some do show benefit, but not consistently. So just keeping that in mind, that metformin may have been spuriously good in that one result. It is still first line, and we still have evidence of benefit, so I think it's reasonable, and not evidence of harm for sure. And then at 10 years, the numbers needed to treat might be somewhere in the 16 to 15 range. Okay. What about the SGLT2s? That's like an empagliflozin type medication. You can see the CVD reduction is around 15%, and it varies. It's up to as high as 30% for death. These are relative numbers, again, please remember, and could be as low as a non-significant 13% reduction. Microvascular is mixed results with the SGLT2s, and if you apply the relative risks and that kind of thing, the MI risk over 10 years has a number needed to treat somewhere between 40 and 72, and death is somewhere around 11, all the way up to 45, which wasn't statistically significant. So this is still beneficial. It's not quite as good as we were seeing with things like statins and blood pressure, but it is helpful and not going the wrong way, or a kind of a null that we see with DPP-4 drugs. Renal outcomes are also down with these by about 27%. And this was the second study that actually found good reduction in true renal outcomes. So that's important to know. GLP-1s, these have a 10 to 25% reduction in CVD, probably somewhere exactly around that 15% if you averaged it out. And death is around 15%. There's some in there that didn't find statistical significance, like semaglutide, lixisenatide, that kind of thing. But if you were a guessing person, you'd say these are helpful in reducing events. Again, microvascular is a bit of a mixed bag. If you look at the number needed to treat over the 10 years, it's somewhere between 9 and 34 here, and death is somewhere between 25 and 34. I see the outcomes for GLP-1s and SGLT2s as very similar in many ways. The real difference is, because don't forget, when we give you these numbers, there's big confidence intervals around them. Mm-hmm. So they can't be a couple percent different and be meaningfully different as a relative reduction. They can't be. But the difference is that SGLT2 seems to have more renal effect. GLP-1s maybe have more weight effect. Remember, weight in and of itself is not an outcome, but it can affect quality of life for the patient. Metformin causes no weight gain, but does cause GI upset, and it costs about $30 a month. The SGLT2s cause genital infections of 6 to 20, number needed to harm, and they do lower BP slightly, but it's trivial. It's often around 1 or 2 points. That's the kind of amount that they're lowering BP. And it costs quite a bit of money. It's $275 every 3 months. And this is the frustrating thing for me when I read this evidence is we've got drugs like the sulfonylureas that are so cheap, but these drugs that actually work and do things are expensive, which is very frustrating. GI upset is number needed to harm between 8 and 80. So it's not great from that perspective. And some have argued that's why it helps lose weight. Others have said, no, that's not the reason. And I don't think we'll ever know. I don't think we'll ever know. Quitting due to adverse events, number needed to harm of 20. And slightly more retinopathy in some studies, but slightly better nephropathy and weight. So not quite as good as the SLGT2s for the kidney, but still looking positive there. Costs $600 to $850 every 3 months. That is a large amount of money. It's also an injection which dissuades many people, but on top of it, it's an incredibly expensive drug, which is very unfortunate. So this leads us to that matrix moment. For those of you who are old enough to remember this, this movie, that you got to choose, which are you going to actually choose, which pill? So Tina's going to take us through the list of drugs that we have.
Right. So this is just a brief summary of all of the drugs that we currently have available for diabetes, starting with metformin at the top, and across the top you can see the effect on cardiovascular disease, death, microvascular outcomes, and then some of the positive and negatives that, for instance, SGLT2, like Mike said, there's definitely some positives, but there's also increase in genital infections and other issues for sure. So what you can see is we have a list here of medications, but when you look at the ones that have improvement in the things that we think patients are most interested in, so cardiovascular disease or death, like in bringing that back to what we see diabetic patients will pass away from most commonly, it really only leaves us with metformin, SGLT2s, and GLP-1s as medications that have RCT evidence of improvement in patient-oriented outcomes at the end.
So this is, again, you can see that I have an affinity for Homer quotes, and this is when he stole the truckload of sugar to try and sell sugar. And first you get the sugar, then you get the power. And I thought that does relate to that's of course a play on the old movie Scarface, but because the white powder analogy. But I do think that this is it does lead in nicely to kind of how do you approach in the most strategic way the problem of sugar. So we've got a couple of simplified algorithms. I'll go through the first one. And the reason that Tina gave me this one is because it's the most simplified. So something that I could handle.
Yeah.
And this is, so you've just recently diagnosed, your patient, or you've recently diagnosed someone with diabetes with high glucose. So what do you do next? You diet like hell. And you try your best to lose your weight and exercise and all of that stuff. And that's what you work at like crazy. And then you're done. That's the new diabetes algorithm. And that is, I would say that's the best diabetes algorithm ever written. Tina, thoughts?
I love it. I love it. I wish we could just end with that one.
Yeah. So, I mean, obviously we know it's hard for people, and I know you feel futile at times talking about this kind of thing, but it is really important for us to remember that this is, we do need to remind patients the power of this.
Yeah, okay. Absolutely. I would agree with that. And so, failing that algorithm. So I love that one. If by some chance you're not having as much success, you could try this algorithm, which is a bit more complex. So you have diabetes. So stop smoking, start exercising, and eat Mediterranean diet. The other thing I love about the Mediterranean diet is the data, when you look at impact on surrogate markers, doesn't seem to make much of a difference, but it does seem to improve the things we care about, which is cardiovascular disease and death. So I would first recommend all of those, and then I would stop and say, okay, what's your blood pressure? And this is a great reminder. I forget this sometimes, even when I'm seeing my diabetics. They'll have come in, we've talked about their A1c, they'll leave, and I hadn't even measured their blood pressure, which has happened to me. But that's actually, the evidence is really supportive of that. So is there hypertension? If there is, we should treat it. So that's pretty good part of the algorithm there. All right, now the other thing is to look at their cardiovascular risk. So this is worthwhile calculating. What is the risk? Use a cardiovascular calculator to determine is their risk higher than 10% in patients. And then if it is, then go ahead and offer a statin. And here, of course, we always encourage that patient-informed decision-making, shared decision-making. Show them your calculator. Show them here's your risk, here's the benefit we can have with the addition of a statin. Which is, again, about 30% plus or minus. So go from there. And then you can look at their sugar. Is their sugar high? Oh, I'm assuming so because they have diabetes. Then we can consider metformin. Metformin should likely be first line, given some evidence of benefit, cost, tolerability, what have you. And then after that, you should likely consider SGLT2s and GLP-1s in your patient population. Now, this isn't a perfect algorithm because these definitely have side effects. We certainly have patients who can't tolerate them. There's cost, but we're sort of stuck between this rock and a hard place where even though we've had this disease with us for many, many years, it's shocking that our management of it is still struggling a little bit. But that's what we would say, best on best available evidence for patient-oriented outcomes. And then if you still can't control their sugar, then consider insulin. And again, starting simple, because that's what we like, simple, just a nighttime long-acting insulin to start with.
Okay, Tina, yeah, I like, this is our kind of simplified algorithm. It's not perfect because it doesn't include costs of SGLT2s and GLP-1s. Some provinces will have trouble accessing those for their patients. So that is by far the biggest problem with this. But if you're going just by the evidence, this is what you would recommend. So we're going to leave you with this last thought. We love this posting. It's a fundraiser, but it doesn't quite work out the way it's written. So this is the Christmas Bazaar and Craft Show. Come fight children with diabetes. I don't think that's what they intended, but yeah, that came out all kinds of wrong. Okay, so we're going to move now to some questions, and we have some questions from people. So I'll close this out, and we'll move here. So sorry, as I read them. Does MI decrease at 10 years versus early diabetes? So what I was trying to show there is that if you're not diabetic, after 10 years, your chance of MI was around 10%. But if you're an early diabetic after 10 years, so you've only had diabetes for when you started, or you got it during that time, and you've had it for less than 10 years, during that next, and actually it's not 10 years, it's over 5 years, your chance of having an MI went up to 14%. And then and if you follow these studies, what it shows is it just keeps getting higher and higher with every year. It's just that I wanted us to understand that early diabetics aren't carrying quite the same risk that diabetics who've had it for 10 years. And that's some of that scary data that Tina showed. Talk about continuous glucose monitoring. Tina, do you want to talk about that, and I'll look through the questions, or do you want me to do?
Well, the continuous, so I'm not sure if that means continuous, like we're talking about the patch that you can wear now,
or the finger pricks. Yeah, I'm not sure.
Yeah, or the fingerprints. So the finger pricks, there is some interesting evidence, because we used to, as soon as you were diagnosed with diabetes, say, well, you should be monitoring your sugars at home, and that was part of that whole quality of life thing that showed that patients who were required to do that, their quality of life was just terrible. And in type 2 diabetics, if they're not on insulin or on medications that are going to they're going to have to adjust, are going to cause hypoglycemia, the evidence suggests that regular monitoring does not help outcomes. In fact, the evidence suggested that it increased depression, increased anxiety, increased patient cost, of course, because they're required to purchase all the strips and everything, which are actually surprisingly costly. Again, things that we're not always told about, but for some patients, that's just, it's not not something that they can do. And so when we are pushing them to do that, it just, again, creates more stress for them. So the evidence, and it doesn't improve outcomes. It doesn't improve outcomes. And those type 2 diabetics who aren't at risk of going hypoglycemic. So what sometimes we tell patients, if you want to check every once in a while, just see, what that giant muffin did to your sugar, sure, go for it. Or that exercise, what that's done, but it shouldn't be something that we're requiring them to do regularly.
Okay, we've got a couple of questions about statins, which we'll try and get through. So the first one is, guidelines say we should put all diabetic patients on statins linked to quality measures. Does that evidence stack up? So I would say not quite. So the problem with that is that what it's based on is the difference between enrollment criteria and who actually enrolls. So what we do a lot of the times in guidelines is we look at not the peer group guidelines, but other guidelines. They look at enrollment criteria into a clinical trial. And if the clinical trial said they were going to do this, then that's the group that they apply that evidence to. But so what the problem there is that the clinical trials all said that they were going to start enrolling patients at age 40. Now, what turned out in the clinical trials of diabetic patients on statins is very few 40-year-old patients were actually in there. In fact, the average age was in the 60s. So I don't think you can take that result. Even though they tried to get patients in their 40s, they got virtually none. So I don't think you can extrapolate that result to a patient in their 40s. They're not the same. They're not that early diabetic who's lower risk, etc. So I think it's better to take and figure out what the risk for that patient is, and then offer them a statin as part of a conversation. That's why we push that approach in the simplified lipid guidelines, because the enrollment criteria. I could spend a ton of time on how we let enrollment criteria in clinical trials end up making blanket statements that likely don't apply to all of our patients. And I think that's one of the flaws with how we approach guidelines in general. So I think that many patients who are diabetic will benefit from a statin, or they're at high enough risk to potentially benefit from a statin. That's a better way to say it. But I don't think that every patient should immediately be pushed to be on a statin. Then the question here is, what about LDL target? What if they're already at target? So if you're a person who's using lipid targets, I have a slightly different approach. I base statin management on risk. But if I was to give you some feedback about lipid targets, the clinical trials that actually took patients who had lipid levels already at 2 and lower, and then gave patients statins based on risk, those patients did just as well regardless. So if I was enrolled in a clinical trial because I'm a smoker and I'm a diabetic and my LDL level is 1.9, if you gave me 10 milligrams of atorvastatin, I would have a 25 to 30% reduction in my chance of having a cardiovascular event. That was shown in the Ascot trial. That was shown in the Jupiter trial. It was, and it's others. I've only listed a few. So it really doesn't matter. I would say that if they're primary prevention, they should be offered a moderate potency like atorvastatin 10 or rosuvastatin low dose. And if they're post MI, I would try and titrate them up to tolerance, something up to 80 of atorvastatin. But remember that the incremental benefits are small. If you look at post-MI studies, over about 3 years or so, they get about a 5% absolute reduction in cardiovascular event from low dose, and they get 1% more from going to high dose. So the most important thing is getting them on a statin, and then if you can eat them up, that's a little bit better. Okay, so there's a question, Tina. I see we're just about out of time, but there was one here on low carb diets having an effect on diabetic outcomes. Do you want to comment on that versus the Mediterranean or others?
Yeah, sure. I can comment a little bit. So the only clinical trials that we're aware of that have shown improvement in cardiovascular outcomes or mortality are the ones looking at Mediterranean diet. So We love looking at diet research though, because there's certainly all sorts of diets out there, low carb diets, there's intermittent fasting diets, and whenever we look at that dietary research, what we find is they all tend to show the same thing: is that you'll lose on average a few kilos, best at about 6 months, and then by a year it's not as good. But what we tend to see is a huge variation in weight loss and weight gain in the population enrolled. So what it tells us is that certain diets work for certain people, and it's probably whichever diet you can adhere to is the diet that's going to work for you. And so some people can adhere to that intermittent fasting diet and they lose a fair amount of weight. Some people can adhere to those ketone diets and they lose a fair amount of weight. And so none of those have shown improvement with cardiovascular outcomes. But if a patient finds a diet that they can tolerate and adhere to, and they can lose some weight and do it in a healthy way, then we would say that is something you should try.
Yeah, and the low carb diets have never been studied long enough or in big enough numbers to show a reduction in cardiovascular events. In cohort data, they actually don't have a positive outcome. Some of them are suggesting harm outcomes, more for like slightly more cardiovascular events, that kind of thing, in observational studies. But remember, they have lots of inherent weaknesses. So that's still a big hole in our understanding. And as Tina mentioned, as for the pure weight loss, it's just a matter of what diet works for your patient. In each example she gave, there were those who lost weight and there were those who gained weight on restricted time eating, on low carbs, on keto diets, all sorts of things. So patients, it's a real mixed bag for what works. I always tell my patients when they tell me they're on a diet, I say, do you think it's working? And if they say yes, then I think that's great. Anyway, we have come to the end. Please check out the chat on the side to pick up the ability to fill out a survey and get a credit for today's, get some certified credit for today's. It's only going to be open until Friday, and today is when you have to actually click on the link, but it has to be completed by the end of Friday. We have another webinar coming up in February 23rd, and it's on primary care approach to common eye problems with Dr. Simon Moore. Many of you will have seen him present. He's awesome. And Christine Richardson. So we encourage you to check that out in just around 1 month's time. Thank you again for listening.
All right, thank you.
See you later.